Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for all attendees. For those who provided a NAB number, credits will be uploaded within the next 2 to 3 weeks. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the chat icon on your screen, and we'll be sure to answer as many of those questions as possible at the end of today's presentation. I'll now turn it over to Jen.
Well, good morning, everyone. My name is Jennifer Dunlap, and I work with Lewis Litigation Support and Clinical Consulting in Butler, Pennsylvania. After some discussions with PHCA, we had decided to kind of discuss some geriatric behaviors because ultimately how we respond to those behaviors eventually could lead to citations for abuse, which has been kind of common in some aspects. So this is a three-part series. Today we're going to discuss the meanings behind the behaviors. It is not all-inclusive. My goal is to kind of get people to think a little differently as to when someone exhibits a behavior does not necessarily mean that's what they're trying to communicate to us. In part 2, we will discuss techniques to try and decrease the behaviors. And then part 3, we are going to discuss trying to help staff. So our objectives for today are there on the screen. And we look at behaviors. There are 4 key categories for behaviors. These ones, verbal aggression, such as accusations, name calling, yelling, making rude comments. And then you have verbal non-aggression, which is your attention seeking, constant mumbling, complaining. And then we look at physical aggression. These are ones that we most notice because, again, there is that physical aspect. So that's when they're biting or scratching us, striking or trying to kick, throwing objects at us, wheeling over people or things. I have had residents where they try to wheel over their cohabitators' feet to try and get attention. Then you have physical non-aggression. That's your inappropriate disrobing, your pacing or wandering, inappropriate handling of objects, such as pulling at tubes, twisting phone cords, dumping the water pitchers, pulling tissues out of the box and throwing them on the floor. And we also have sundowning. Sundowning is something that most long-term care healthcare workers are aware of. It is an impaired circadian rhythm. So it's a state of confusion that occurs late afternoon, lasting into the night. As 3 to 11 supervisor for a number of years, I was very familiar with sundowning and those residents who would exhibit that. This can be the cause of the behaviors, or it can exacerbate behaviors that they've already been exhibiting. They somehow get a burst of energy towards the evening hours. And the factors that may aggravate it are fatigue, spending the day in an unfamiliar place, low lighting, increased shadows, difficulty separating reality from dreams, being hungry or thirsty, the presence of an infection, being bored or in pain, or depression. So let's think for a moment. Have you ever cried when you were angry? I know I have. Have you ever smiled when you're uncomfortable? You know, sometimes when you're in front of people and they're saying things that just make you uncomfortable, you just kind of grin. But do those behaviors always exhibit how you are feeling at that moment? So that's something we want to think about ourselves. You know, my husband tells me all the time that I have a scowl on my face. And why am I angry? Well, I'm not angry. You know, I am just constantly thinking of various things that I need to do or, you know, get in touch with someone. and that's my resting face, has a scowl on it. So what the other person is perceiving of me does not match how I'm feeling at that moment. We do this with ourselves. So we really need to think, our residents do this as well. And have you ever been with a crying infant? So what are some of the reasons that they're crying? Are they bored? Sad? In pain? Are they teething? Are they wet? Are they fussy because they're sleepy? Hungry? They don't feel good? Kids get a lot of ear infections. Is that why this child is crying? Do they want held? These are just examples of how to think differently about the behaviors that our residents exhibit, because sometimes behaviors are our residents' way to communicate, just as it does for an infant. So we have some factors for behavioral responses, whether that's a personal experience and something triggers us to think back, a learned response from how we were brought up or how we have learned to respond to people, places, and things, our environment, our inborn tendencies or genetics, our reaction to others. As we age, there are changes in our brain, whether that's the capacity, our memory, the ability to comprehend, or is there a loss of control because our brain isn't functioning the same way it did when we were younger? Is it possible that we have dementia? And these are early symptoms of the dementia that we are uh, progressing towards. Is there a neurological change? Sometimes we have, atrophy of the brain. We have ischemia of the brain. Was there a stroke? So factors are important for us to realize that as our body is progressing in the aging process, there are changes. And looking at common reasons for behavior or triggers for certain behaviors, um, pain or discomfort. We know that people that are in pain come off as angry or not wanting us to care for them, because maybe when we turn and reposition them, they are just they have pain. They want space. This could be somebody that has lived alone for years on end, and now they are in a facility with all of these people around them. They just want some space and privacy. Fatigue. They can't do what they used to do. So the more that they do physically, the faster that they get fatigued. They feel overwhelmed. Again, we're in a facility now, and there's all of these different people around us, and they may not recognize these people, so they're feeling overwhelmed. Noise is a huge trigger. Um, you have call bells going off, you have people hollering, you have people talking, you have phones going off. You have all of this noise, and it makes the person, overwhelmed, or it triggers them. Medical conditions, such as a UTI. We know that people can experience various behaviors because of a UTI. And how many physicians always say, oh, there's a behavior, collect a urine. The change of an environment. Sometimes the acting out is just an extension of the way the person has always acted. So are we going to ask the family, is this how your mom or dad has always responded? Are there new medications that the person is on? Maybe it's a side effect of the medication or an adverse effect. Had past trauma or loss. The older we get, the more people we have lost in our lives. And sometimes that just makes us exhibit behaviors. Unmet physical or emotional needs, such as toileting, hunger, sleep, thirst, fear. Fear is probably the biggest reason for a behavior, because we don't comprehend, we don't remember why we're in this facility. We don't remember the people that are around us, and it is fearful. You have to think to yourself, if someone blindfolded you and took you to a city that you have never been to, puts you out of the vehicle and tells you, here you go, you're on your own. It's fearful. Even though we are trying to care for that person, we are trying to give them what they need. They don't recognize that. What they recognize is, I don't know my surroundings. I don't know what I'm supposed to do, and I'm fearful. Confusion, whether that's related to dementia or not, anger, and we have dulled senses. We start to have vision changes. We have hearing problems. Our smell is decreased. Sometimes those are part of the reason the person is hollering, because they can't hear other people as well. So they're hollering. Plus the perceptions. Sometimes, as I said earlier, how my husband perceives me is not how I want to be presented, but that is his perception. So he will react in that because that's how he sees me. So we're going to give some examples as to why behaviors may be exhibited. And again, this is not all inclusive, but my goal is to try and get you to think differently. We have verbal aggression. A person is name calling or calling out to you constantly. Is it possible that they are trying to get you to respond and they're attention seeking? Is it possible that they are fearful, so they just want somebody in that room with them? A fear of dying, and I don't want to die alone, so I want somebody in here with me. Or are they trying to communicate and can't get those words out? I'm hungry, but they can't get those words of hunger out. You never want to take what somebody says personally. I have had residents, call me fat, various obscenities, mean. You can't take it personally. If these individuals were in tip-top shape, they would not be with us. They need us. So we can never take what they do or say to us personally. We need to understand why they are doing this and maybe try to help them. Hoarding. How many times have you seen residents go in and out of other resident rooms and take things and take it back to their room? Or they have so many items in their room that you run out of space because they're hoarding. Well, have some of these residents been through the Depression? Back at that time, they had very minimal. So when they see things and nobody's around and they take it, that's their survival. They have to have those things to survive. They worry about money. A lot of residents talk about how they're going to pay for things, or they need to go to their job today because they have to make money to eat. These are fears that they have due to their past history. A fear of loss of memories. Sometimes they hoard because they're holding on to things because it reminds them of someone or something, or a time in their life in which they were happy. Maybe they collected various items. So their goal is, when they see something that they used to collect, they take it with them so they have it. Anger. Sometimes in our life, we have these transitions that we're not happy with. How many residents say, I don't want to be in a nursing home. I don't want to be here. So they're angry. They're angry that their life is where it is at the present time. They're angry because they have lost autonomy and independence. They're angry because now people are telling them what to do and when to do it. They're angry because this is how their life has progressed and not where they wanted it to be. They become angry because the body and the brain starts to slow down. and we can't do the things we used to do. I have times where I'm talking to somebody and I know what I want to say, but I can't get the words out of my mouth. And I get angry. And it's just because I have so many other things going on that I just can't articulate what I want at that point in time. So imagine what that would be like, 20, 30, 40 years down the road. Sometimes the resident exhibits abuse towards the caregiver. And one of those reasons is because you're the one that is there. I always tell parents that have trouble with their children and behaviors, why is my child doing this to me? Well, because you're the one that is there. They feel safe with you, so they feel that they can use you as their outlet. Sometimes that's like that with our residents too. Have you ever had that resident that you have such a good rapport with all of a sudden start yelling at you and trying to hurt you and you don't know why? Well, they may feel comfortable because they know that you will still be there for them no matter what. They're feeling rushed, overwhelmed. In our facilities, we are so task oriented because we have so much to do in so little time. And if you feel rushed, imagine what the resident feels like as you're doing these tasks on or with them. They also feel rushed. You have residents who are suspicious or paranoid. Sometimes it's because they forgot. They forgot that they put their wallet in their drawer. So now they accuse you of taking it. Sometimes they're just blaming others because they can't do what they used to do. You have the wanderers. Are they searching for that familiar environment? Are they looking for something? Whether that's food or clothes or another person that they know is familiar to them. How many times have you had residents say, I'm going to work today? And they just start wandering around. Well, that was what was familiar to them. Working was something that they always did. They feel like they still need to do it. Or I'm going to find my mother, because they are looking for something familiar and they forgot that mother has passed away. Overall, you have those residents who are just attention seeking. I always call these residents the Jeopardy players, the ones that are on the call bells every 2 minutes. Well, they could be attention seeking. Again, that fear of being alone. I keep seeing people walk uh, by my doorway, but they never come in to see me. So I'm pushing on the call bell. I have pain. I'm pushing on the call bell. We always tell our residents, push this button if you need anything. Well, in their mind, they keep thinking that they need something, or they think of things that they may need, just to get you to come into the room and give them some attention. Sometimes our residents are affection seeking. I want somebody to show that they care for me. I'm feeling alone. I'm feeling like nobody cares. So they're looking for affection. We have residents who refuse care or hygiene. And this is probably one of the biggest behaviors that is most documented, because they don't allow us to give them baths. They're refusing to allow us to give them incontinence care. They may not want to be eating. Sometimes it's because of modesty. Residents do not want to be naked and vulnerable in front of others. It is just something that they grew up with. They were not to be nude in front of anyone but their significant other. So this is hard for them. There may be a decreased sense of smell. So you may smell the urine or the VM, but they can't smell it. So they don't think that they need incontinence care. Being cold. This is also one that we have to monitor because they may not want you to take their brief off because they get cold very quickly, or they don't want to get in the shower because, again, I get cold, so I don't want to be naked in this water. A fear of water. I have had residents who absolutely refuse to get a shower because they have a fear of water, whether it was they saw a drowning when they were young, or they almost drowned when they were young, or it's not something that they normally did. They always just washed up at the sink. They have that fear. And in relation to that, a history of not bathing. Some people only bathed once a week or once every other week. They couldn't afford water, or they didn't have water readily accessible to them. So they didn't bathe as often as we're trying to bathe them. This is where we want to kind of get a little history of our residents and determine what their routines were. We're bringing them into a facility, we're disrupting their life, and we're disrupting all the routines that they had. What can we possibly do to try and help them remain in that routine? You have residents who are biting you or spitting on you or striking out. Well, they may fear you. They may not remember you. They may not realize that you're there to help them. They may have a fear that you're trying to hurt them. Sometimes they are shoving you and pushing you away because as you're rolling them in bed, it is uncomfortable to them. So instead of being able to articulate to you what's going on, they're hitting or they're kicking. Another one is a fear of falling out of bed. You are rolling these people around in their bed, and they have a fear of falling. Getting them up in a lift. Again, a fear of falling. Even though we know that's what the lift is there for, they don't always understand that. You know, what if 10 years ago they fell and broke their hip and went through all of the trials and tribulations after that? Well, they don't want to fall again. So that's why they have these issues with mobility, and they're not able to articulate what is going on. We have those residents who inappropriately disrobe. Sometimes it's because they're hot. You know, sometimes the clothes that we put on them seem appropriate for us, but not for that resident. So if you have somebody that's constantly stripping off their clothes, they may be too hot in the environment that they're in. Or they may feel like they're wet, so they're trying to get their clothes off because they urinated. Our residents have a decline in health. That's why they're with us. That leads to sadness, that leads to anger. If they have the ability to comprehend that their health is declining and they are now having to rely on others, it brings up emotions. The emotions that we have are exhibited in those various ways that we've been discussing. Sometimes having a little bit of empathy towards what the resident is experiencing is what helps us to care for our residents to the best of our ability. If a resident refuses food or fluids, is it because there's a decrease in motor skills and they can't feed themselves now? Sometimes when residents are unable to do these simple tasks, they feel ashamed or embarrassed. So then they start to refuse, or they push us away because of these emotions that they're going through. Again, do they have a decreased sense of smell or taste? So maybe they don't like the food that we're providing them. And our food is usually more on the bland level because we, have to serve all of these people with various issues. So maybe we need to spice it up a little bit for them. Is there a dental problem? They having chewing or swallowing difficulties? When's the last time speech therapy saw them? Maybe that's why they're refusing to eat or drink. They're on a restricted diet, so they don't want it. Or it's not part of their routine. I have had residents, some residents never ate breakfast. That's just not what they did. They just started their day, and then at noon they'd have a small lunch, and then they'd have a dinner. So we're trying to feed them at a time that they never ate. Some residents look at what we are providing them on their meal tray, and it's overwhelming to them. Then you have sexual disinhibition and hypersexuality. Well, that could be because of a lack of privacy. Sometimes they kind of give you a different perspective. Because we don't give them enough privacy, they kind of over exhibit their sexuality. Or is there a need for intimacy? Some of this also stems back to the medications that we have residents on, their various medical issues, or a combination. So that's why in the second part, we're going to discuss some ways to kind of look at this in various aspects. But this also makes us think back. You know, there are some medications that seem very benign when we give it to them. But when you have an issue where you may have, especially males who seem to be hypersexual, when you have the pharmacist look back, some of their medications that they're on, that is an adverse or side effect to that. Because of the other medications they're on, because of what it does to the brain chemistry. So these are all things that we need to think of. Some of this is also an adjustment issue. So the most challenging window for residents is within the first 6 weeks following arrival to a new facility. It is hard for them to adjust. I want you to think of the first day at a new job. Were you able to just go into that job and hit it head on, know where everything was, know everyone you were working with, know exactly what your tasks were, what you were responsible for? We don't all know that. So it's also important to remember that as a resident comes into our facility, this is all new to them. They're being hit, when they first get to us with various assessments, paperwork that needs filled out, handbooks, new residents, new roommates, new routines. We're hitting them a lot. That's why in the first 6 weeks, it's more important to kind of stand back and think about what our resident is going through. The adjustment can be associated with anxiety or insomnia, anger, depression, because now they're considering home to be where they used to live prior to coming to the facility. And we're now telling them this is your home. It's confusing to them. It makes them angry. And it's not where they're comfortable. So part of what we want to do is look at the 5 W's regarding behaviors. Who is around when the behavior exists? Is there another resident that seems to be around when this resident exhibits the behavior? Sometimes when you see one person, it reminds you of someone else that has been in your life. And that person you may be fearful of, you may just really dislike. They may have done something to you, or it could be the reverse, and it's somebody that you really adore and want to be around. So if this person becomes hypersexual, well, is that when Miss Jane is around all the time? Maybe she reminds him of his wife. What are the triggers? So is there something going on at that time? Is the trigger a specific food? Is it when they go get the shower? Is it when they're in the hallway? Is it at night? And that leads to us, when does the behavior occur? Is there a specific time of day that this behavior occurs? In long-term care, we tend to chart by exception. However, I tried to tell my aides and my nurses to chart the behavior every time it happens. Do not assume that this is so-and-so's baseline and she's always acting like that. No, please continue to chart for two reasons. One, it helps us to determine when the behavior occurs. It's much better if we can chart right at the point of occurrence so we can kind of get a time frame. And two, there may be things that we are doing in the back end that you're not aware of. There may be a new medication. There may be a counselor that they're talking to. Psych is involved. If you just stop charting on those behaviors, we may assume that what we're doing is working. So continue to chart behaviors, even if it is their quote unquote baseline. Where is a specific place that the behavior occurs? Is it usually in their room? Maybe they're feeling lonely in that room, or they're disliking their roommate, or they feel claustrophobic. Is it in the hallway? Is it in the dining room? That's kind of important too, because sometimes our surroundings are also increase the behavior. And why is this behavior happening? That's kind of ways that we're going to look in part 2 as to why the behaviors are happening. But I'm hoping that this kind of gives the different way of thought and may help us to answer the question, why is the behavior happening? So some of the questions we need to ask: what are the behaviors? What non-pharmacological interventions have been attempted? If you have a resident that is continuously screaming out every time we roll them back and forth in bed, have we tried 2 individuals? Have we tried a different person to provide that care? Have we checked to see if they're in pain and maybe they need some, massage or heat therapy? Has it been discussed with the family what the old habits are? We have discussed some of the history of residents, whether it was in the Depression or their collections or, um, their habits of meal times. Have we discussed with the family? Again, getting to know our residents helps us to care for them. When was the last gradual dose reduction? Is this possibly medication related? Is there a psych consult? And a lot of times with psych comes the counselor. Is there a way that we can have the resident discuss their feelings? They may be coherent enough to understand why they're feeling the way they are and just need somebody to listen. Are there any medical, social, emotional, physical, or psychological issues that we haven't looked at? And does the behavior put someone at risk? That is probably the number one question I always want people to ask. Residents are allowed to exhibit behaviors. We all do it. But is that putting that resident or someone else at risk? If you have a resident who becomes physically aggressive, is that putting our staff at risk? Is that putting that resident at risk? Or is there a chance that this resident may hurt others? That is one of the biggest things we need to ask. We always talk about resident rights, and the residents have the right for various things, but they do not have the right to hurt themselves or someone else. So we just need to make sure that they are safe. We also need to look at dementia care principles. As we discussed earlier, sometimes our behaviors are leading to the diagnosis of dementia. Dementia is ruining our brain, and that's what's changing how we are behaving. So we need to look at person-centered care. quality and quantity of staff. Again, sometimes we develop such a good rapport with our residents that they feel most comfortable with us. So if I'm there for the day, Ms. Doe wants me to take care of her today because she feels comfortable with me. Or is it they feel better when there's two staff members versus one to take care of them? You need to have a thorough evaluation of new or worsening behaviors. Sometimes the behaviors are a precursor to dementia, or it can be the dementia is the cause of the behaviors. If it is a precursor to dementia, we know that we have medications out there to slow the progression. Is it possible that we can start one of these medications and help so the resident doesn't progress? The individualized approaches to care, we know that that's a big thing, individualized care plans, ensuring that we are providing this resident with what they need from us. Really critically think usage of antipsychotic drug use. Department of Health, CMS, they really are buckling down on antipsychotic usage. So what have we done in lieu of using a drug? Have we started low and went slow? Have we tried GDRs? Have we tried various therapies versus just going to a medication? Interviews with prescribers, again, that's just looking at the various medications and seeing if we're taking the appropriate steps, and engaging the resident and or the representative in decision making. As much as we can, we need to try and keep our resident a part of their care. So as we have went through this, my goal was to try and get everyone to think a little differently. You know, I put on here, please remember that I may not act the same way I feel. I also want to reiterate that we cannot take things personally as to what our residents do to us. In numerous years, I think I've only had one resident who was intentional with her behaviors, saying, and she was younger, but saying that if I have to be here and I have to be sick, my goal is to make you sick as well. That is rare. That is not the norm. Residents usually do not want to hurt others, but they don't know what else to do. So I just want to remind everybody that our goal is to try and find out why the residents are acting this way and think differently. So I got done a little earlier than expected. Kim, do we have any questions or?
It does not appear that we have any questions, which is a-okay. As always, feel free to submit your questions to myself or Jennifer via email. And San said this was very good, thank you. So thanks again, and we will see everyone again next month. If you've signed up or registered for the part 2, we'll see you then. Thanks so much,
Sounds
Jennifer.
great. Thank you.